thank you, Frank, for joining us tonight. Dr. Frank Cahill is a sleep psychologist. He's our guest tonight. Also online, as you can see, Associate Professor Michael Stubbs and sleep physician Dr. Linda Schachter. So hello and welcome, everyone. For those of you, if you just missed that first part, Peter Field's my name. I represent the Dental Solution. I'm based here in Sydney. Michael and Linda are part of the Respiratory Dental Institute, which is based in Melbourne. Frank, I'd just like to welcome you tonight. Thank you for taking the time out of your busy schedule, number one, to be here, number two, for preparing tonight's presentation. If you've been listening to us, we have been chatting about sleep problems that have arisen because of basically the COVID lockdown and how this is affecting people. So sleep is a bigger problem than just what we do with oral medicine, splints. It's a huge problem and obviously has many different facets. So Frank, thanks for coming along tonight to cover those off. I'm going to hand straight over to you, Frank. I'll just change the setting up here so that we disappear, and it's all yours.
Thanks, Peter. We're good to go. So welcome everybody, and thanks for joining us this evening. This evening we're going to be talking about sleep, obviously, and I think it's very topical based on what we've been experiencing most recently. And I love this graphic that you can probably see on the screen here, because I think it represents how we all kind of feel at the moment, that we'd rather stay under the covers than actually face the world at the moment. But since the pandemic, there's been a significant increase in the amount of insomnia that's been recorded. And that's been represented in a number of research articles. If you go online and start accessing them, you'll see there's an enormous amount of research that's currently taking place, looking at the impact that the pandemic has been having on people's sleeping patterns. And of course, with that, comorbidities such as anxiety and depression. So tonight I'm going to go through understanding the psychology of sleep and particularly how to treat insomnia. I'm also going to tie it in with obstructive sleep apnea, because I know you have an interest. The participants out there are very interested in the role of treating apnea, but insomnia and apnea tend to kind of be interwoven. So I'm going to have a look at that. We're going to talk about the nature of how insomnia starts and then how it's perpetuated. And then we're going to look at the treatment associated with it. And I'm talking about the gold standard treatment, which is cognitive behavioral therapy for insomnia. And I'll be talking to you about what that looks like. And also I'll be presenting a case study. So you'll actually see the application of sleep psychology dealing with insomnia. And then I want to open it up to questions. And I'd like to have assign a good percentage of this particular talk to any questions that come up so we can get a discussion going. So there are some out there that may be having some issues associated with your sleep. So you probably get a lot out of this talk tonight. There might be others that have problems with, may have relatives, also may have patients that you know are struggling with sleep. Now here you can give them some strategies. So let's get underway. So probably the first thing I want to look at here is the relationship between OSA, obstructive sleep apnea, and insomnia. And there is a very strong relationship. We know that around about 40 to 55% of patients with obstructive sleep apnea actually report symptoms of insomnia. And we know about 30 to 70% of patients with insomnia have an apnea hypopnea index of greater than 5. And we also know that sleep maintenance, insomnia, is probably the most frequently reported complaint associated with obstructive sleep apnea. So by sleep maintenance, what we're talking about is people who can often get to sleep, but they wake a lot during the night. But interesting enough, even when obstructive sleep apnea is actually treated, often insomnia symptoms can actually be relieved. But at the same time, people who present with obstructive sleep apnea and have it treated with a MAS or a CPAP therapy, the treatment itself can actually cause insomnia as people have difficulty actually complying with the measures that are undertaken to actually treat the insomnia. So I'm often treating OSA patients that are struggling with CPAP or MAS devices, or I'm treating people who present with insomnia that actually have OSA. So trying to work out the difference between the two is very, very important. So let's have a look at what makes up the structure of insomnia. And this is the 4-factor model of insomnia, which I think is absolutely terrific. It's actually informed the work that I've done as a sleep psychologist. And it actually helps me process and get a better understanding about what I'm dealing with. So in this particular model, this is the 4-factor model, which was developed by Perlis and Spielman. And what it does, it talks a little bit about the nature of insomnia. So down here on the left, we have what we call the premorbid condition. So a premorbid condition is anybody who has may have a potential for developing insomnia. And these are people who might be a little bit more on the anxious side. They could be type A personalities are a good classic, good example of that. So type A personalities generally like to control things. So when things get out of control, they usually struggle, and insomnia is one aspect that.
That's me.
That
Andrea,
yeah,
sorry, Andrea, I wondered if you could mute your computer, please.
Oh, okay.
Thank you.
Yeah.
There we go. So type A personalities are very susceptible to developing insomnia. There is an hereditary component with insomnia. We often find it runs in the family. So poor parents often who have difficulty, parents who have poor sleep habits, we often see that also within the children. So then we have the next stage that we experience is what we call in the acute stage is what we call a precipitating event. Now, what sets off insomnia is usually an event. It could be stress that a person might be experiencing. It could be conflict in a relationship. It could be stress in a particular job that they're involved in. But as we know, we've all been experienced enormous amount of stress with the pandemic and the development of COVID-19 and the current cases that have been experienced in Australia and in this current wave. And the lockdowns as well, that has been a precipitating effect for lots of people because they've been stuck at home. They've had to do homeschooling, they've had to work from home, they've been restricted in their in what they can do in terms of how far they can travel. Their leisure activities all been has been restricted. So that's increased an enormous amount of stress and anxiety. And with this comes insomnia. So typically with insomnia, once the precipitating events have been resolved, we often see the resolution of insomnia. It gets below this threshold period, which is where threshold level, which is the mark where insomnia becomes problematic. But what actually happens is sometimes when the problem gets resolved that caused the insomnia, sometimes the insomnia stays around and it doesn't get resolved. It just keeps on going. And that's because the patient develops what we call perpetuating factors. And perpetuating factors are the things that people will do to try and control sleep. And these are things like typically sleeping in if they haven't slept well, which reduces their sleep drive, sleeping in the morning, having naps in the afternoon, a range of different things that can actually, going to bed too early, a range of different things that can actually keep the insomnia alive. And I'm going to talk a lot about perpetuating factors and how to treat them. The other factor that can occur in insomnia and the development of insomnia is a thing called a conditional arousal response. The best way I can describe it is being bitten by the backyard dog. Often I use this term when I see a client who comes in that's very anxious about their sleep. And I say, you've been bitten by the backyard dog. You've been friends with the backyard dog for many, many years, meaning they used to be able to go to bed and be able to sleep quite comfortably. But for one reason or another, they got to a point where they started to struggle with trying to fall asleep. And after a while, they start losing their confidence. It's a bit like you go into the backyard and you get bitten by a dog, the family dog. You think, I think all the people still got have them muted. So after a while, you tend to lose your confidence. And this is what we call a conditional arousal response. And I've seen people actually get into, because they're so anxious about the night ahead, because they've had a period of not sleeping, and they're thinking about, will I get to sleep tonight? And as they approach the bed at night, I've actually had people having panic attacks in bed, because then the brain has now associated the bed as not a safe place, is a dangerous place. This is a place where I'm going to spend the whole night struggling trying to get to sleep. So there's this conditional arousal response that occurs, either going to bed or trying to get to sleep, or if they're in the pattern of waking in the middle of the night and not going back to sleep, they get a conditional arousal response there, where they wake at the same time in the middle of the night and they go, oh my God, how am I going to get back to sleep again? And then they start struggling. So, so this is where we really develop chronic insomnia. So how do we treat it? Well, the way we treat it is we attack the perpetuating factors, all the mistakes that people do or make that actually are perpetuating the insomnia. And when we attack it, and we attack it with cognitive behavioral therapy for insomnia, and it's the gold standard treatment for dealing with insomnia. What we find is that it doesn't take too many sessions actually to bring it down. But once we get it down to below threshold levels, we're then able to continue working with the patient, and eventually we get it back down to baseline. And it's extremely successful. So let's have a look at some of the perpetuating factors. These are the things that we are looking for, we're targeting. So when I'm working with the clients, it's a little bit like forensic work, where you're looking for all the things that may be contributing to their insomnia. So let's have a look at the basic one. So it's what we do to make up for a bad night's sleep. And the classic is going to bed early or sleeping in. So if I've had a bad night's sleep, my first reaction is try to sleep in and to catch up on sleep. But what that effectively does is it reduces our overall sleep drive, which means that we're probably less tired at the time in which we'd normally go to bed. And a lot of people also think if I go to bed early, I might be able to maximize the opportunity of falling asleep. But a lot of people then go to bed before they're actually able to go to sleep. Hence, they spend more time in bed. They spend more time getting frustrated, and that increases their anxiety and their conditional arousal response. Other things we look for is things that people do the next day to make up for a bad night's sleep. So these are things like napping, having afternoon naps, reducing physical activity and putting off events and meetings and work and social events are kind of really interesting. People, when a person isn't sleeping well, the first thing they do is they try to protect their sleep. It's a bit like when you get a broken arm, you try to protect it, so you put it in a sling. In the same way, people tend to adopt those sort of behaviors when they've had a bad night's sleep. So they tend to put off things they'd normally do, like physical activities, events, social meetings. Some people are frightened to go out at night at social activities because they feel they have to be in bed at a certain time. So all this is putting pressure on their next night's sleep. And it basically starts building this kind of belief that I have to have a good night's sleep in order to do anything productive the next day. So it kind of feeds into this fear that they have every night about I have to have a good night's sleep. So putting things off the next day can perpetuate the insomnia cycle. The other thing too is anything we do in bed other than sleep and sex, should be in brackets there. Reading, I don't know. I think a lot of people read before bed, so I give that one a tick. But generally things like watching TV, problem solving, worrying about issues, or worrying about not sleeping and lying in bed awake for long periods of time can lead to frustration. Peter, can we get rid of, just down the column there, we've got Linda and Debbie. Are we able to take that off so we can, so it doesn't cut off the text?
Is that it?
No, I think Linda and Debbie are still there.
I can't see it at my end, Frank, sorry.
Oh, okay. All right, can you see a full screen?
Yes.
Okay, well, it must be from my end. Okay. The other thing that a perpetuating factor we're looking for with people who have difficulty sleeping is sleep hygiene, which is kind of really interesting. When people go to the doctor or they usually go for help, for their sleep, probably the first thing they get met with is sleep hygiene. And sleep hygiene is good in many ways, but when a person is not sleeping well and they're very anxious about their sleep or worried, what they often do is they either often overdose on sleep hygiene. They often do all the things that they think they should do to get a good night's sleep, like, you know, turning down lights, turning off screens about 2 or 3 hours beforehand, making sure that, you know, they're doing their relaxation. And what that actually does, it actually can work against the person because they're doing all these things or trying to do all the right things leading into bed, and then they get into bed and they're wide awake. It often creates a feeling of failure that they've tried everything that they've read about sleep hygiene, and all it actually does, particularly for people with chronic insomnia, it actually puts a lot more pressure on them to sleep. And it feeds into this conditional arousal response and then can feed into perpetuating their insomnia. So I'm very careful when I'm talking to people to look at how religiously they're applying sleep hygiene strategies and where they're overdoing it. So let's have a look at the whole psychological process of insomnia. So it can be basically broken into a couple of key areas. So what are we looking for insomnia? Well, basically anxiety about getting to sleep, and extended sleep onsets. So those two represent what we call sleep onset insomnia, difficulty going to bed and difficulty initiating sleep. And a lot of people with sleep onset insomnia, often once they do fall asleep, they generally sleep for the rest of the night, but they can take hours and hours to actually fall asleep. So with that becomes an enormous amount of anxiety. The other component associated with insomnia is what we call sleep maintenance insomnia. So that's waking a lot during the night and often for long periods during the night. And the other component that we see in presenting with insomnia is early morning waking. So people with sleep maintenance insomnia generally can fall asleep pretty well, but they wake a lot during the night, and they can wake for 2 or 3 hours in the middle of the night and be quite frustrated. People with early morning waking usually can fall asleep okay. They usually don't wake much at all during the night until about 3 o'clock or 4 o'clock in the morning, and then they can't go back to sleep. So this is what we call early morning waking. It's often associated with either depression. We see it a lot in depressive clients who wake at 3 or 4 in the morning and struggle to return to sleep, and they're usually just ruminating over things in their life. Or the other group of individuals we see with early morning waking are those who have got a lot on. They've got a lot of stress going on. They live a very busy life, or they're thinking about work and their mind just goes pings on. We often see this in the ADHD presentations as well. They tend to wake early in the morning and they can't switch off their active mind. So how do you treat it? Well, treatment options, medication and CBTI. Usually a lot of people with insomnia, their first approach is to go to the GP, and usually when they present with the GP, they're often very, very anxious, and understandably the GP often provides them with sleeping medications. Now, sleeping medications have a place and they're very useful, but they're also a very slippery slope, because after a while people can start becoming highly dependent on them. And after a while, they develop this kind of belief that I can't get to sleep without medication. And this becomes evident when you start trying to get them off the medication. And as you're trying to get off the medication, you can see the whites of their eyes. So they start getting very, very anxious. So it's hard work getting people off that. The other treatment, of course, which we're going to be looking at today, is CBTI. And CBTI can be very useful in helping people get off sleeping medication. Sometimes with people who are suffering from really struggling with their insomnia, it makes sense to put them on sleeping medication for a period of time, because it enables them to function effectively. And that can be very important for their mental health. So it does have a place, but CBTI should also be introduced either in conjunction with medication or on its own. So let's have a look at, when we talk about cognitive behavioural therapy for insomnia, what's it made up of? So it's made up of 5 different components. First one, sleep hygiene, which we've spoken about. So they're all the things that we do before bed to create the right environment to fall asleep, and making sure that we're not napping during the day. We're going to bed when we're tired. We're not drinking, a bottle of Coke or too many coffees in the evening. And we're minimizing our use of alcohol and so forth. It also involves, CBTI also involves relaxation therapy, which can be very useful for lowering cortisol levels and lowering arousal levels. So these are things like progressive muscle relaxation or meditation can be very, very helpful as well. In terms of calming a quiet mind. It also involves stimulus control. So stimulus control is where we associate the bed with sleep and we try to get everything out from that. So if you're not sleeping, stimulus control would suggest that you should not be in your bed, but we're going to talk a little bit more about that. So it's associating the bed with sleep and avoiding or limiting stimulating behaviour in there. And stimulating behaviour would be playing on your phone, would be a good example of that. It also, CBTI also involves a thing called sleep restriction therapy. Now, sleep restriction therapy basically involves restricting the person's time in bed to match the amount of sleep that they're getting. A lot of people who struggle with sleep will often go to bed too early. They'll spend a lot of time in bed late in the morning. So, for example, a person who is, let's say, spending 10 hours in bed and maybe getting 5 hours sleep, then it doesn't make much sense to kind of keep them in bed for that period of time for 10 hours. So sleep restriction therapy is about putting them in bed for 5 to 6 hours to match the amount of sleep that they have, match their time in bed with the amount of sleep that they're getting. And it's quite an effective process, which I'm going to talk a little bit more about. And the other one is cognitive therapy, which really challenges unhelpful thoughts about sleep. I would say a good percentage of insomnia-related issues are associated with fear and anxiety about sleep itself, and there's usually core fears that underpin a person's fear about their insomnia, which actually is one of the major perpetuating factors. And probably top of the list would be, I have to have a good night's sleep in order to function the next day. That's probably top of the list of the most strong cognitions or core beliefs that actually feed into insomnia. So when we look at applying CBTI, it's made up of those 5 categories. But the reality is, in treating it in practice, is that the top 3 that we use is stimulus control, sleep restriction, and cognitive therapy. Relaxation therapy is quite good. I use it appropriately, but I usually don't spend a lot of time on sleep hygiene, because most of the people that I see that present with significant sleeping problems have already covered sleep hygiene. They've always been presented with sleep hygiene. They've all been given tips to how to get to sleep. And at this point, this is not an effective approach for people who have chronic insomnia. So let's have a look at, so my major focus is around these top 3: stimulus control, sleep restriction, and cognitive therapy, which is where I'd like to talk a little bit more about. So let's talk about stimulus control. Stimulus control is most effective for people who have difficulty falling asleep, or what we call sleep onset insomnia. So what's it made up of? Well, as we mentioned before, it's limiting a person's time in bed, limiting the activities that people are involved in bed, and limiting those activities to things like sleeping and sex. Reading, a lot of people will go to bed to read with a book, and they find that that's part of their normal approach. I usually don't have a problem with that, but spending a long time in bed playing on their phones is a major problem. Playing on their iPad, because the impact of bright light can have on their circadian rhythm, it can actually cause a high degree of stimulation. So definitely we want to limit those activities. And the other thing in terms of stimulus control, which ties in with sleep onset insomnia, is that people with sleep onset insomnia generally spend a long time in bed trying to get to sleep. And the longer they lie in bed, the harder it gets, the more frustrated they get, and the more anxious they get. So it's kind of important to get people out of bed. Generally what I do, and this is probably at the heart of stimulus control in terms of getting people out of bed. If you look at some of the earlier research, they used to say if the person hasn't fallen asleep within 20 minutes, get them out of bed and do something non-too stimulating until they feel tired, like ironing or reading or whatever, until they feel tired, and then you go back to bed. But in practice, what I found is that doesn't work that well. What we find is when people, if they haven't fallen asleep within 20 minutes, they get out of bed. What I found is that I've had clients come back to me where they've spent most of the night just getting out of bed every 20 minutes and then just going back every 20 minutes. What I find is more, and they usually don't get tired, they just get more and more anxious. What I find works quite well is if a person is struggling to get to sleep and they're getting frustrated, I usually get them out of bed for a 10-minute reset and break. And what I find is useful here is that when they get out of bed for a 10-minute reset, it actually enables them to cool their body temperature down. And we know sleep is associated with a fall in body temperature. Lying in bed for long periods of time, you often find there's an increase in body temperature, and sleep's associated with a fall in body temperature. So I find if a person's struggling to get to sleep, I ask them to get out of bed for a short 10-minute break, and then we get them back into bed and just focus on resting. And this is like this paradoxical intent that I talk a lot about to people. People who struggle to get to sleep, they're often trying to control sleep, and they can't. It's one of the most difficult things where you can't control sleep. It's something that actually happens. So my focus is to get people to go back to bed and just focus on resting. Now, they can repeat that a couple of times, but generally I want people to lie there and rest and focus on resting rather than trying to get to sleep. So stimulus control is probably the first line defense associated with people who have struggling to get to sleep. That plus cognitive therapy, which we're going to get into. The other thing too, which is really important, is to stop clock watching. A lot of people will who are struggling to get to sleep, whether they're trying to get to sleep or they wake a lot during the night, they'll clock watch. And clock watching is deadly, because all you end up doing is calculating how much sleep you got left before you have to get up the next day. So it actually increases anxiety. So generally I get people to get rid of the clock. Sleep restriction. Sleep restriction is, what was that?
I'll mute.
Thank you. Sleep restriction is probably best used for sleep maintenance insomnia. So as I mentioned before, this is where we control the person's time in bed to match their sleep efficiency. And I'll give you an example of what that looks like. I've got a slide up here. So this is a sleep diary. Before a person comes in for a session, I get them to complete a DAS, which is the depression, anxiety, and stress scale. So I get a sense of what's going on in their, in terms of their mood disorders. But the sleep diary is very, very useful to work out what the pattern is that the person is presenting in terms of their sleep. So the way you read a sleep diary, pretty straightforward. You'll notice we've got the times up here. So we've got 11 and 12, and then throughout the morning. The arrow down indicates when they attempted to go to bed, or when they went to bed and attempted to go to sleep. And you can see that varied a little bit, but it's within the range. So this person went to bed about 11, 11:30, sometimes 12. The white spots indicate the fact that they weren't asleep, they were awake, and the black spots indicate where they thought they fell asleep. So as you can see from this one, the arrows up indicate when they got up for the morning. But looking at this, that would scare you, wouldn't it? There's a person that's really struggling with lots of things. They're struggling to fall asleep, so they have sleep onset insomnia. And you've got some sleep maintenance insomnia as well, where they do fall asleep, but they continue to wake throughout the night for long periods. So you have a person who is struggling with both sleep onset and sleep maintenance insomnia. Now, if you have a look at how long the person's in bed for, they're in bed at 11, going to bed 11, and oh my God, they're getting up at noon. Is that right? Yeah, noon and 11. So they're almost in their bed for about 12 hours, which is enormous. So here we have a complete mismatch between the time in bed and the amount of sleep they're actually getting. And if you have a look over here, the total sleep time, we've got 3 hours, 3.5, 1. But you notice after about 1.5 hours, they have a night of 5 hours. So you can see how when their sleep is restricted, it tends to increase a little bit. So here we had 7 hours, then 5, then 4, then 7, then 1, then 5. So typically what we see is good nights follow bad nights, and that's the nature of sleep drive. So when a person's sleep drive has been restricted, their sleep has been restricted, it actually increases their sleep drive, which often has a good impact on the next night. So how would I treat this individual? Well, it's a couple of ways I'd go, but I think you can see how sleep restriction would work here. If we restricted the person's time in bed, let's say for 6 hours, which would be fair if we went to say from 12 to 6 a.m., what we typically start to see is that those black spots start coming together and the sleep becomes more consolidated. Typically what we do is we get them to restrict their time in bed for about 2 weeks. And it takes about 3 or 4 days before we see the impact of a sleep restriction therapy in improving sleep. But after a while, this homeostatic sleep drive starts to build and build. And then we start to see more consolidated sleep in a lot of the cases. And then after about, and what that does, it actually teaches the person to go to bed and fall asleep, but it also teaches them if they wake in the middle of the night, how to go back to sleep. And then after about 2 weeks, the idea is then to slowly increase their time in bed till they get to a reasonable bed time, which should be around about 8 hours time in bed, 7 to 8 hours. So that's how sleep restriction works. The other one is a common presentation that we see is early morning waking. So we have sleep onset insomnia, which is treated with stimulus control. We have sleep maintenance insomnia, which is often treated with sleep restriction therapy. And then we have early morning waking, which is very common among professionals who have very busy lives. They tend to crash, they fall asleep at a certain time, but they tend to wake at the same time, about 4 o'clock in the morning, 3 or 4, and they struggle to go back to sleep. So how do we treat this one? Well, generally, if the first thing I get people to do, if they wake in the middle of the night, often what they'll do is they'll stay in bed, which is perpetuating the problem. I usually get them out of bed for a 10-minute cool down reset. That's the first thing I do. And that drops their body temperature. And that in itself can be very successful in breaking the pattern. The second thing is when I get them back to bed, I get them to focus on resting and drifting rather than trying to get to sleep. A lot of people, when they wake at 4 in the morning, they think they've got to get back to sleep, and it just starts putting more pressure on them. And of course, their mind runs about all the things they've got to do on the next day. The other thing too is, well, coming back to this one, going to bed and coming back to bed and focus on resting and drifting. There's a phenomenon called sleep state misperception, which is where the person could be lying in bed for 2 or 3 hours and swear black and blue that they're awake. In actual fact, they can be asleep. And there are basically 3 things that will tell you that's occurred. The first thing is that time goes quickly. So if you wake at, say, 4 in the morning and you lie there and you just rest and your eyes are closed and you swear black and blue, you're awake from, say, 4 to 6 when the alarm went off. If you got a sense that time went pretty quickly, the chances are you're asleep without even realizing. The third thing that can often tell you that you could be asleep when you thought you're awake is that your thinking becomes relatively bizarre. So you're lying there thinking about work and all of a sudden you're in the jungle chasing lions and tigers, which kind of indicates that you've actually fallen asleep, gone through a REM period, and you're reflecting on a dream. And probably the third and the most important thing is that even though you thought you're awake from, say, 4 to 6, your daytime energy wasn't that bad, which probably signals the fact that you might have been sleeping more. So when I talk about sleep state misperception, that can often occur for people who wake a lot in the middle of the night or the latter part of the night, the emphasis on just resting their body and drifting and knowing that they could be asleep without even realizing sort of helps them stop the struggle of trying to go back to sleep. The other thing too, with at that time of the night, a lot of people have very active minds where they're starting to think about things. And I often talk a lot about good thoughts and bad thoughts at this time of the night. So good thoughts are, I guess, memories, could be retracing the dream that they had. It could be conversations with friends. Bad thoughts are things that keep them up. And it's usually thinking and worrying, or it could be planning. A lot of people who wake at this time of the night are very good at planning. They're planning the day. They're planning issues that they need to go through or work through the next day. So we often talk about using a diffusion technique. And a diffusion technique, in its essence, is noticing when you're having those kind of thoughts that are not helpful, to just get in the habit of saying, let it go, and bring your attention back to something else. Sometimes it can be useful to have an imagery process. A lot of people use an office shredder in their own imagination. So when they start having anxious thoughts or thoughts that they know are going to keep them up, they can imagine just putting through an office shredder or putting on a leaf and letting it float down the stream. Or coming up with some sort of way of kind of diffusing. Some people put in a book and slam the book. Other people kind of put in a box. Some people stick in the microwave. Some people drop in the ocean. Some people flush in the toilet. It's a way of kind of getting out of your head. But my argument to people is that you're either feeding it or you're starving it at that time of the night. So I encourage people to starve it and just turn their attention to something else and just focus on resting and drifting. And sleep state misperception, you might be asleep without even realizing it. So that's how we treat, I've got another one in there. Yeah, that's how we treat what we call early morning waking. But the main thing is to basically see your sleep in two parts. If you have a pattern of waking at 4 o'clock in the morning, see your sleep in two parts. You've already had a good solid block. You've got your slow wave sleep and your deep sleep. The second part of the night, it's really important to just focus on resting your body and without struggling of trying to go back to sleep. And often when you take that attitude, you can often be asleep without even realizing. Sometimes I introduce sleep restriction. That can help, meaning that if a person who wakes a lot, say 4 o'clock in the morning, sometimes I might look at what time they're going to bed, and sometimes I might actually restrict their time in bed by making them go to bed a little bit later, and that increase in sleep pressure can often break the early morning waking pattern as well. So this is probably the biggest area of challenge associated with dealing with insomnia is the anxiety, because it's often driven by fear. There's always a fear associated with insomnia. Will I fall asleep tonight? And as I mentioned before, one of the main perpetuating fears associated with insomnia is that I have to have a good night's sleep in order to function the next day. There are other fears that actually feed into insomnia, and that is the impact that health has. And a lot of people, if you read anything in the local news or lifestyle magazines, they'll talk about the importance of sleep, and then they'll refer to all the research that ties poor sleep with health disorders such as early onset of dementia, cardiovascular diseases, diabetes, a whole range of different things. Now, when people read that, if they're struggling with insomnia, it just really feeds the insomnia. So trying to get people to have a more balanced view about those particular issues is really important. So cognitive therapy is very much about identifying what their core fear is, and then really challenging the validity of that particular fear. So the way we do this, and this is where cognitive therapy comes into it. So in cognitive therapy, what we need to do is we need to really challenge a core belief and maybe replace it with a more helpful belief. So for people who actually have difficulty falling asleep, their biggest desire is wanting to control that process. So I always I've got a whole list of sayings that I go through with clients, but one of the top ones for sleep onset insomnia is the belief that at some time tonight I'll fall asleep. Until then, I'm happy to drift. And then I ask the client, is that true? And they say, well, I don't know. I worry if I fall asleep. And then you have to have a look at their sleep diaries. They typically do fall asleep at some point at the night. So in the meantime, just lying there and relaxing is going to facilitate that. And I let them know they can't control sleep, but we look at the things they can control. They can control the time they go to bed, the time they get up. They can control their body temperature if they need to get out of bed, and they can control their attitude, but they can't control sleep. The other one is related to this one, the belief that I have to have a good night's sleep in order to function the next day. And the antidote statement is, it is okay to have a bad night. We all do have them. And regardless of how much sleep I get tonight, I'll get through tomorrow like every other day. So how do you challenge this one with them? Well, you look at their sleep diary and you typically look at a day or a night where they probably got 2 or 3 hours sleep. And you ask, how do they get through the day? And typically they'll say, well, yeah, it wasn't great, but I got through the day. And you ask them, what did they do? And some of them are in professions. Some of them are doing, technical work, and they typically get through the day. And I say, how do you do that? He said, well, I don't get the energy at the time. So I then say, is the statement true? And they say, well, yeah, I guess it is true. I do get through the day. But the thing is that insomnia is fed by a core belief that I have to sleep in order to function the next day. But when you present them with data, that actually their own data that suggests that they are able to get through the day regardless of how much sleep, it kind of helps reduce the threat. In a sense, what I'm trying to do is I'm trying to get people to decatastrophize a bad night's sleep, to take the fear out of not sleeping. If I can do that, then I can get them to be more relaxed. When they're more relaxed about their sleep, they're more likely to sleep. And the last one here is this one, which I really like. Resting peacefully is almost as a restorer of sleep. If I'm not sleeping, all I need to do is lie here and rest my body. Now, this is a line that your grandma probably mentioned to you, or your mother might have said to you, if you're not sleeping, darling, just kind of lie there and rest. And there's a lot of there's a lot of value in this. A lot of my clients say, is it true? And I say, well, is it as good as sleep? Well, probably not. But then I say, is the statement helpful? And they usually say, well, yeah, it is. It is helpful because it changes my whole perspective. And so if you can't sleep, you look at what you can do. So you can lie there and rest. And typically, if you do lie there and rest, this concept around sleep state misperception is more likely to take hold and you're more likely to fall asleep. And I often say to clients, there are basically all the work around insomnia can be brought down to two core principles. The first one is stop trying to get to sleep. And the second one is stop worrying about not sleeping. If you can get your head around those two principles, then you can often address the insomnia. And the other one is reclaim the day. A lot of people put things off during the day. And if you reclaim the day, it's amazing what can happen. I had a woman I was treating once who had all these safety behaviors during the day, and she would really put a lot of things off. And I said to her, based on whether she had a good night's sleep or not, and I said, look, regardless of how much sleep you have, I want you to just go about your business, do everything you would have normally put off. And she came back about 2 or 3 weeks later, and she said, I said, how are you sleeping? She said, great. And I said, what happened? She said, well, it was really, really hard. I pushed through and I did all the things I would normally do if I was sleeping well. And what happened was I was so tired by the end of the day, I was sleeping like a baby. So it was quite interesting, the concept of reclaiming the day. So let's have a look at a case study and then we'll kind of open up for questions. This is a 30-year-old female with sleep onset insomnia and had a sleep latency ranging from about 30 minutes to about several hours. She had significant sleep-related anxiety, and the core belief was I must get sleep tonight, otherwise I won't be able to function the next day, leading to, and this was interesting, I said to her, what would it mean to you if you don't get a good night, if you don't function well the next day? And she said, it would mean that I wouldn't be able to do all the things I need to do. I would be cranky and I would snap at my children. And I said, what would that mean if you were doing that? And she said, it would mean I'd be a bad mother, and I don't want to be a bad mother. So her concept about being a good mother was tied up with the fact that she had to have a good night's sleep in order to be a good mother. So you can see how this core belief kind of feeds into the insomnia. Perpetuating factors. The other thing too, occasionally she would use temazepam, and if she wasn't sleeping, she might get up and have 2 shots of rum to help her get to sleep. She would engage in a significant number of safety behaviors that would debrief. She would debrief her sleep every morning with her husband. So what were the perpetuating factors? Well, lying in bed, awake for long periods of time in bed, her pre-bed safety behaviors, the use of alcohol and temazepam use, and catastrophizing about her sleep and talking about her sleep. When a person talks about their sleep to all and sundry, it just feeds it and it becomes this big snowball effect. What were her safety behaviors? Well, there were quite a few of them. These are these sleep hygiene things that people put into place that actually put more pressure on getting to sleep. Green tea before bed, earplugs, because she was sensitive to any sleep-related threats. Listening to meditation audios in bed. Don't have a problem with that if you're using meditation to actually get to sleep as opposed to relaxing. That can be a safety behavior. Lavender drops on the pillow, hot shower before bed. That's not such a major thing, but if you weren't doing it before the sleep problem happened, then it's a safety behavior. 30 minutes of exercise on the bike to help her get to sleep before bed. She'd complete a gratitude diary, turn the screens and TVs off by 8 o'clock because of everything she read about screens. Turn off all lights down around about 8 o'clock, and she actually changed the light bulbs to lower amplitudes. So it wouldn't affect her sleep, it wouldn't affect her circadian rhythm. She put on blue light blocking glasses around 8 o'clock. She slept in a separate bed from her husband because she didn't want to be disturbed, and she put off significant events during the day. So these are all safety behaviors, and they just fed into her anxiety about her sleep. And that's what her sleep looked like, which was pretty horrific. You get nights of one sleep, and this is all driven by anxiety. A little bit of sleep maintenance, but she was going to bed about 10:30, and she's getting up around about 8. She was, you can see this pattern, but you can also see the pattern that good nights follow bad nights. So we've got a bad night, good night, not so good, bad night, and then it starts to increase. See how the sleep pressure increases, and then a bad night, and then a good night. And that's the nature of sleep restriction. So that would tell me she's a good candidate for sleep restriction. So what was the treatment plan? Well, the first thing, I got rid of all the sleep safety behaviours. A lot of patients, when you tell them to get rid of their safety behaviours before bed, they get the sense of relief. And I often ask them to go back to what they used to do before the problem started. And that's often a great sense of relief for them, so it takes the pressure off them. For this one, stimulus control, okay, if you're awake and restless, out of bed for 10 minutes, cool down, otherwise stay in bed. Meaning that if she's relaxed and lying in bed, even though she thinks she's awake, I'd stay there because you've got more chance of falling asleep, but only get out of bed if you're restless. I did decide to do a sleep restriction for this one, 11:30 to 6, which proved to be quite effective. But I don't always do sleep restriction for sleep onset anxiety, but in this case, it was effective. And we did CBT to address her, cognitive therapy to address her unhelpful thoughts, particularly about the fact that she was a bad mother if she didn't get a good night's sleep. And we did mindfulness strategies for erasing thoughts at night. We shifted the focus from sleeping to resting. That's something she could control. And then we got her to stop talking about her sleep to her husband in the morning. And when a person stops talking about their sleep, they actually start taking ownership of their sleep rather than trying to share it with everyone else in the hope that they could take the pain away. And I got her to reclaim the day, which she found very, very effective. And she responded very well after about 3 weeks of treatment, sleeping quite well. I don't have a sleep diary with me, but it was a good case. So that, I think, is pretty much a wrap up around how I would approach insomnia, how it ties in. It's pretty straightforward work for the most part. It's often people respond very well to the behavioural strategies associated with dealing with insomnia, which is stimulus control and sleep restriction, but often also require some work around addressing what the core fear is. And addressing that can actually make a big difference, take the anxiety associated with falling asleep. So Pete, I might just throw it back to you. Do we have any questions on the panel, or anybody have any questions about their own sleep or sleep of a friend?
You can unmute your computers now, people, and yeah, Frank's there to take your questions. Frank, I was going to say thank you so much again. Another very informative, wonderful talk. If someone wishes to see you, do they need a referral from their GP?
Yeah. I would definitely go to the GP first and discuss the best line of treatment with the GP first.
Yeah. Very good. And if someone wished, if some of our Melbourne viewers wanted to come and see you personally, they would get a referral from their GP and just give you a ring at Sleep with Confidence. Is that right?
Yeah, absolutely.
Yeah. If you've got space, I understand you're very busy.
That's right.
Any questions? I'll throw it open.
Thanks, Frank. That was great. I've got a couple of questions.
Go, Linda. Go.
I suppose there were a number of behaviours that I saw that this lady was doing, that I thought, I mean, the exercise at 7:30, what do you feel about exercise in that sort of quite close to bedtime period?
Yeah, look, it's a kind of a really interesting one. Exercise, there's a lot of research that says that exercise late in the evening can actually, depending on what it is, it can increase body temperature, and then it's the shower and the wind down and the fall in body temperature can help you fall asleep. For me, it's not so much what they're doing, it's why they're doing it. If they're doing it because they desperately want to maximize every opportunity to fall asleep, then in my mind, it's a safety behavior that should be eliminated. If these are behaviors that they used to do before the problem started, then I'd say continue doing it. So it really has a lot to do with the why rather than the what, from my perspective. So exercise at 7:30 in the evening, totally fine. A lot of people go to the gym, but this was a woman that never did it before, and she took that on board because somebody said, or she read, that doing some exercise could wear you out and make you more tired. And of course, what happens, when she was doing that, it would have some She was complying to that sort of advice, but of course she'd get into bed and she'd be wide awake, and her first thought was, geez, I've done everything I need to do, but nothing seems to be working. And a lot of clients often talk about the term work. It didn't work, or I tried that and it didn't work. So they get this sense of helplessness and hopelessness, which sort of feeds into the insomnia.
The other thing is the alcohol. And I suppose one of the things from my own personal experience from recently stopping drinking at all for a number of months was just how much, and I was only drinking maybe 1 or 2 glasses every so often, but how much the alcohol actually did affect the quality of my sleep. When, you know, I was quite shocked with stopping drinking, how much even only 1 or 2 drinks actually had such a significant impact on the quality of sleep.
Yeah. What did you notice? Was it the waking a lot during the night, or the nature?
Yeah, it was waking a lot during that sleep fragmentation had gone. So I wasn't waking at all during the night. And I've done lots of sleep studies on myself. So I know that, you know, don't have sleep apnea, but it was really, even 1 or 2 drinks was actually having that sort of effect on my sleep.
Yeah, it is true. It's interesting. A lot of people have just in the habit of taking 1 or 2 glasses a night, and some people doesn't really affect their sleep. Some people it does. I know if you have just that extra one, sometimes it really does affect the quality of the sleep. But as we know, alcohol generally puts people to sleep, but it fragments their sleep during the night and affects sleep maintenance issues. It's a bugger.
And obviously makes their sleep apnea worse as well. So, you know, another thing to be wary of. Do you actually get them to stop drinking for a period of time to see if that has an impact on their sleep?
Yeah, I do. Look, it really depends on how much alcohol they're drinking. If they're drinking every night, yep, that's kind of a flag for me. A lot of people will kind of abstain during the week and maybe just the weekend, so I usually don't worry about that. I'll check how much alcohol they're taking. And then I'll just ask them to experiment. I'm a big one for experimenting, meaning that rather than say, look, don't drink because it's not good for you, I say, well, why don't you experiment not taking it during the week and just see what impact that has on your sleep. I do the same with caffeine, because different people have different kind of tolerances towards caffeine. Some people can take, 2 or 3 or even 4 and have no impact. Some people can take a cup of coffee to bed with them and have no impact. Others, if they're drinking a lot of caffeine and they scale right back on it, it makes a significant difference. I remember I was working with an old she must have been about 78-year-old woman, and she had fragmented sleep and had for years. And I said, do you drink coffee? And she said, oh, no, dear, I don't drink coffee. It's terrible stuff. And I said, what about tea? And she said, oh, yes, I like my tea. And I said, well, how many cups of tea do you have? And she said about 8 or 9 during the day. And I thought, oh, okay, well, let's experiment. Let's cut it back. But I didn't say stop, because she would have gone into withdrawal symptoms after so many years drinking it. She got down to about 2 cups a day and she was sleeping like a baby. So something as simple as that can have a major impact on it. So I kind of look at what they're doing and I get them to experiment with it. And they're often quite surprised by the results.
2 things I'll just quickly mention. That decaf coffee does have caffeine in it. So that's number 1, a much significantly smaller amount. And then the green tea does still have caffeine in it. So that woman that was actually having green tea at night, obviously, while a lower dose of caffeine. Just the other thing is, I recently had a patient who was only having 2 cups of coffee in the morning. And I said, again, the trial thing, let's try stopping caffeine for a week. She goes, oh my goodness, I don't think I could do it. I said, no, look, your sleep's bad, let's try it for a week. And even with 2 cups of coffee in the morning, it was having a significant impact on her sleep at night. So I think that half-life of caffeine in some people is actually significantly longer than I think it may be.
Yes, indeed.
Frank, thank you for an excellent presentation. I was going to ask you a question in regards to insomnia.
Yeah.
Is there any difference between males and females in the incidence?
Yeah, absolutely. Significant difference between male and females. Females are more likely, in terms of anxiety, they tend to score higher on levels of anxiety than males in surveys that have been done. But in terms of the presentation of insomnia, I think it's about 1.6 times more likely to have insomnia than males. There's some stat out there, but definitely, if you have a look at all the research online, females often score higher on the insomnia severity index and quality of sleep than males do. What's your experience, Linda? Linda?
Yeah, sorry about that. I was just unmuting. Yeah, I agree with you. I think females definitely do have higher anxiety scores. And I think part of it is they actually see it as an issue more too. So they might actually still have the same sleep issues, but for the female, it's a significant, their anxiety about their insomnia is actually significantly higher too. I actually had a patient ring me today who's a lady with very severe chronic insomnia who we've got her managed quite well recently. And she missed one night of sleep and ringing me, oh my God, I slept poorly last night. What do I do? And I calm down, you'll be fine. But unfortunately, that anxiety about the insomnia can be so enormous that even one night of poor sleep, she's just so terrified of going back into this bad spiral.
Oh yeah, it's like a trauma in a way. You know what I seeing most in this pandemic are people who used to be great sleepers, and these are people who go to bed at a set time, they'd be out like a light, wouldn't budge during the night, and they'd sleep right through. Always been great sleepers, and they've stopped sleeping, and they might have had a bad night, and they've never had a bad night in their life before. And then they think, oh God, what's wrong? Something strange. And then that turns their attention to it. And then a couple of nights later, they get a bad night and it starts feeding on it. And that's where the anxiety comes from. If you've got somebody who's gone from a great sleeper to all of a sudden become a bad sleeper, the anxiety just goes through the roof. And it's almost like a trauma. And Linda, you would have seen these patients where they've ended up in ER where they haven't slept for about 5 days in a row. And they've been put on meds and so forth. That in itself becomes, from a trauma perspective, that becomes like a trauma that that's stuck in their trauma memory network. So what that means, and if their sleep then recovers, and that event might have happened 2 or 3 years ago, but if their sleep then recovers, if they have a bad night, it brings back the trauma associated with that original experience of the 5 nights of not sleeping. And actually, I've done a lot of trauma work with people who suffer from sleep onset insomnia, targeting the original insomnia. And here we often use EMDR, which is eye movement desensitization reprocessing, which is designed for people who've gone through trauma. And we use that a lot to help them overcome the original trauma and to reinstall the statement that, it's over now, I'm safe. It's over now, I'm better, rather than here we go again, I'm going to go back to what we had before. So those original trauma experiences in relation to sleep are quite significant. And they're one of the major perpetuating factors associated with ongoing sleep anxiety.
I agree with you. And I almost think in some of them, it is almost like a post-traumatic stress disorder. Yeah. And I talk to them about when they're next stressed about anything, it's going to present as insomnia. And so how to deal with it in that case, and just almost preempting that, not trying to get them anxious about it, but just that when it does happen, that they're not terrified and they're actually can cope with it without, that initial terrible anxiety the first time they're awake again at 3 a.m.
Correct. And they know what to do. They know the strategies to take place. Absolutely. It is. It's quite interesting, particularly those who've slept well and all of a sudden they're not sleeping. That's where the biggest issues are.
I must say though, Frank, I mean, I should actually see if there's any other questions while we're chatting. But very quickly, when I did go through my divorce, I mean, from being a good sleeper to being a terrible sleeper, that took several months to get back to being a reasonable sleeper. And I don't think I'll ever be as good as what I was before. But it is quite traumatic to be awake at 3 o'clock every day 3 a.m. every day for several months. And then you start realizing why these patients are so agitated and so worried about when they do wake up, which obviously self-perpetuates the problem that you are going to wake up at the same time each day.
It destroys people's lives. It actually takes over their life because they feel they just cannot function in their life. Well, that's the perception. And that concept of reclaiming the day is a really tough one, but such an important one. The things that they tend to put off. And I get people to a state, or some people get to a state where they are just sick of their insomnia. And I ask how do you feel about your insomnia? How do you feel about it taking over your life? You're angry about it? You're frustrated with it? And often they say, yeah. And I say, well, look, I want you to stop sleeping. And when people come to me, I say, I'm not interested in giving you tips to get to sleep because everybody's done that. I'm just interested in you stop trying to get to sleep. That's the key. And once people kind of get their heads around that, they just go to bed, because all of us who are kind of reasonable sleepers out there would typically, we go to bed at night. We don't think about whether we're going to go to sleep. We just lie there with our thoughts, and all of a sudden, we're gone. Nobody knows when we fall asleep. But people are struggling to get to sleep. They're just lying in bed waiting to get to sleep, and they become very kind of hyper aware of the fact that they're not asleep. And then the whole thing just feeds, just like wildfire, it feeds. So it's trying to bring them back to baseline. But you're right, Linda, it's dealing, for the most part, you're dealing with anxiety and frustration. It's tough. But CBTI is very, very effective in treating it. There's no question about it, and very efficient. Any other questions out there?
No other questions. Oh.
Can you hear me?
Mm-hmm.
Thanks for the sharing, Frank. Can I please ask, in terms of treatment with medication, do you see melatonin? Is there a place for melatonin? Is it effective?
Yeah, well, Linda and I were having this chat earlier before we started. You might have overheard it. I'll give my views on it. Linda can give her views on it. When people are highly anxious before bed, melatonin usually doesn't work. Isn't usually not that effective because the cortisol levels cortisol levels can and anxiety levels can override any kind of sleeping medication. You can give people enough medication to kill a small horse, and they can still be awake throughout the night if they're super anxious. But coming back to melatonin, I tend to use it a lot with circadian rhythm disorders. This is where we have particularly delayed sleep phase disorders, where a person's circadian rhythm is sort of shifted, where they used to fall asleep at, say, 10 or 11. Now that's shifted out to 3 or 4 in the morning, and then they're sleeping on till about 10 or 11 in the morning. And melatonin can be quite useful in terms of the timing of it. So we often use very small amounts, usually about 5 hours before their sleep onset time. And then what we do is we slowly advance that amount of medication as we advance their wake-up time. So melatonin can be very useful in circadian rhythm disorders. Circadin is probably the most widely used melatonin on the market. That's a slow-release melatonin, 2 milligrams, which is used for sleep maintenance insomnia. If you can break it up into half, you can turn it to 1 milligram of rapid release melatonin. That can be very useful about an hour before a person goes to bed. It's probably a good starting point for medications because it's quite soft, and it can be effective for some, but not for all. And it probably might be a lot better starting point than introducing benzos for some people. What are your thoughts, Linda?
I suppose there's a couple of things with insomnia, and number one is if you look at the data on circadian or with any melatonin, and we'll talk about circadian first and then over-the-counter melatonin, because they are really two different things. Yeah. So the data on circadian is really predominantly in the over 50-year-olds, and it actually does show improvement in sleep maintenance insomnia of about 60 to 70% of cases. So, the data is there that it is going to improve in people who are over 50 and have some problems with sleep maintenance insomnia. The other thing with it is, and I suppose where I see it's quite helpful, there is actually quite a big placebo effect with medication, in inverted commas, in insomnia, either sleep onset or sleep maintenance insomnia, and probably the placebo effect is somewhere around 30 to 40%. So if you ever read a trial about insomnia, make sure that there's a placebo arm, because the placebo effect is enormous. Mm-hmm. Yes, I do use it, and I use it quite a lot. And it is a really good first step in trying to do it. Obviously, as you're trying to do all of the other things and you're getting them to the psychologist to do CBTI and you're doing sleep hygiene. over-the-counter melatonin, there's been some studies where they've actually looked at the amount of melatonin in some of the over-the-counter melatonin formulas, and there is actually an enormous variation, even despite what it actually says on the bottle. So if you are going to give melatonin and they say, well, I've got this stuff from overseas, I bought it in the States quite cheaply, and you can buy melatonin very cheaply overseas, anywhere from 1 milligram to 10 milligrams. But if on all of the studies, the amount of melatonin that is in the tablets is quite variable. So I usually say, look, you know, let's get you onto melatonin here. And then if you want to actually try something from overseas, try it and then see if you get a similar effect. Because even if you do use melatonin from a compounding pharmacy, which I sometimes do, it can be quite expensive. So yes, I use it. You do need to follow up to make sure it's effective. And actually, Circadian has become has changed its schedule. So if you are over 50, you can get one script over the counter now.
Thank you.
Thanks, Linda. Were there any other questions from the group, please? Doesn't sound like it. Well, we've had 14 people listening very intently all night, and they're still with us. So thank you everyone for turning up. Once again, on behalf of the Dental Solution and Respiratory Dental Institute, thank you. Frank, thanks again for a marvellous talk. And with that, we'll say good night.
Thank you, everybody.
Thank you,
everyone.
And thanks, Frank. Excellent.
No
Thank
worries.
you.
See you later.
Bye.